Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to What Clinicians Want to Know About Toxicity Considerations Associated with BTK Inhibitors. We have a great faculty today, Dr. Nicole Lamanna from the Herbert Irving Comprehensive Cancer Center at Columbia University in New York, and Dr. Bill Wierda from the MD Anderson Cancer Center in Houston. As always, if you have any questions or cases you'd like to run by us, just type them into the chat room. We'll talk about as many of these as we have time today. As always, we have a 1-minute pre- and post-meeting survey for you to take in the chat room. If you take that, we'll learn a little bit more about you, and you'll get a lot more out of this meeting. We do webinars all the time, but also live meetings. So we're heading out to Bill's neck of the woods to the Soho meeting in Houston. We'll be doing 2 CME satellite programs next Thursday. We'll also be broadcasting these or virtually, so if you want to check it out next Thursday night, we'll be doing a program on myelofibrosis, and then the next day I'll be doing a program again with Bill's colleague Chris Flowers looking at diffuse large B-cell lymphoma. On September 11th, we have a great program focused on triple-negative breast cancer. Then we'll be working with Katie Moore on September 14th, talking about ovarian cancer. A lot going on in localized non-small cell cancer, particularly the integration of targeted immunotherapy. We'll talk about that in the end of September. And then I'm really looking forward to this program on mantle cell that we're going to be doing on September 26th. And actually, I'm going to make a little comment about that because actually we know a lot of people end up listening to our programs. They like podcasts. If you are into that, check out our Oncology Today podcast series, including a recent program I did with Dr. Wang talking about mantle cell lymphoma. We'll get into that a lot more in the mantle cell seminar in a couple weeks, but I did want to bring up what he had to say about BTK inhibitors, which I found very, very interesting. But we are here to talk about toxicity with BTK inhibitors, prevention and management. And as we do many times, we have a bunch of community-based general medical oncologists. They're going to be doing short presentations. I meet with these docs separately. We record many presentations, and we edit them down to very short videos. So we're going to try to see how many of these cases we can present. So we're going to mix that in also with a survey that we did of general medical oncologists. We actually recruited 55 general medical oncologists, and we'll tell you a little bit about that survey in a second. But first, I'm just kind of starting out because actually, as I was going through the cases with one of the docs, I realized that Dr. Bachow, who we've worked with many times presenting cases here from Boca Raton, we're in Miami, was actually one of Nicole's fellows. And in fact, a couple of these patients he sent back to you, Nicole. And so I thought we'd just I'm curious from both of you, just before we get started. It's really amazing when you think about how these docs, he presented cases to me of ovarian cancer, bladder cancer, every part of oncology, very knowledgeable. What's it like for you to work with these docs and then see them go into practice, Nicole?
No, it's great. I mean, obviously, man, if I could have kept Spencer, I would have. But certainly he is a Floridian at heart. And so all his family is down there, and now he's an independent doc, and now obviously not junior anymore and not a fellow. So he has a big practice and he's doing really well. But what's great is, having trained with me, I trust him empirically. I know that he knows the heme malignancies really well. And it's great because there's a lot of New Yorkers that go to Florida, and we have a lot of those snowbirds. So I send a lot of patients to Spencer. And so, it's a great, he's still got my cell phone. We text all the time, and it's nice to continue that relationship, and as he continues to build his practice, obviously not just in CLL, but other cancers as well. So he's doing really well, and it makes me feel old, but also really proud.
Bill, any thoughts? It's really amazing when you think about the spectrum, and you think about all the fellows that are out there, not only in the United States and other countries that you've trained over the years. Any comments?
No, I mean, I would agree with Nicole. It's great to see the ones that go into community practice. It's also very gratifying to see those who we worked with and go into academic positions and do great work at other institutions and build their own programs. So that's been very gratifying also to see sort of spreading the knowledge and lighting the fire of enthusiasm and interest in CLL for me is very gratifying to see.
So before we get into the cases, just to comment a little bit more about this survey that we just did over the last couple of weeks. Again, these are general medical oncologists. We were actually asking them about a bunch of hematologic cancers, and as I mentioned, we asked them to come up with 5 questions to ask you in this webinar. So I sat down with about 270 questions to try to figure out which ones to present. And actually, I was thinking that maybe I could use some kind of AI to sort of figure this out, but I couldn't. I should have asked Bill because he was explaining to me how I could have done that, but I didn't have any other way to do it than the more traditional way. And somebody reminded me, I didn't even remember what Max had. Probably, most of the people here don't even know who this is, but this sort of predated computers, this concept. And so I just had a little fun here and thinking about myself being the actual AI that's going to be presenting these questions. And I thought maybe we could just kind of start with just a couple of them, and then we'll get into the cases. So Nicole, this is a very common question people have. They've got a patient who's been on ibrutinib for a long time. They hear about issues with ibrutinib and that the new generation's better. Should they switch a patient who's doing well to a second generation agent like acala or Zanu? Particularly, I think I hear more and more people concerned about ventricular arrhythmias with ibrutinib. What do you say when people bring up this possibility, Nicole?
Yeah, I mean, in my practice, if somebody has been doing really, really well on ibrutinib, I traditionally, or I still have not necessarily switched them over if they otherwise are asymptomatic and doing well. Now, similar to the CML story, I don't start many new patients, to be honest, on ibrutinib. So if they're going to start a BTK, I'm going to start them on one of the newer agents because of the toxicity profile from the head-to-head studies. But, in my experience, if somebody's already doing, is on 4 years of ibrutinib and doing fine, the likelihood is they're going to be fine. And so I really do not switch them over unless there's a major concern and they feel that they have to. But I don't do that typically.
Bill, any comments?
I completely agree. I mean, we don't switch patients who are doing well on off of ibrutinib onto another agent.
Are there situations right now outside a clinical trial, Nicole, where you will start somebody on ibrutinib?
No, I think I answered that. So no. I'm typically, as long as their insurance is covering either acala or Zanu, I'm typically, if they're going to go on a BTK for the first time, I'm typically using a newer agent. Yeah, that's what I'm typically doing.
And I was just pointing out to the faculty, you probably, if anybody saw the New York Times this morning, they had a cover on the front page of article about this thing they're going to try with negotiating through Medicare, and they picked 10 drugs. I was curious how many of them were going to be cancer drugs, and only one was a cancer drug. And it actually was ibrutinib, amazingly enough. Kind of wondering how they came up with that, given the fact that fewer and fewer people are starting it. What about this other case that was brought up here? I'm sorry, Bill, did you want to comment?
Yeah, just a quick comment. So you asked Nicole if there was anybody she would start first line on ibrutinib. Right. The one patient that comes to mind would be a patient who I'm thinking about giving ibrutinib plus venetoclax as a frontline therapy or a relapsed treatment. We have a lot of data with ibrutinib plus venetoclax. That's a very potent combination for fixed duration treatment to achieve an undetectable MRD status. I think the data with that combination is very strong, and we don't have that data with other combinations of BTK plus venetoclax. So if I'm thinking about putting a patient on combined BTK plus BCL2 inhibitor, ibrutinib would be where I start. I usually give 3 months of ibrutinib, like's been done in the clinical trials, and then add the venetoclax for the fixed duration treatment.
And if you were seeing a second opinion, Bill, of somebody who's going to do acala and venetoclax, would that be okay with you, or not? You don't think that's
I would
a good way to go?
Yeah, I would not recommend that until we have some data that substantiates that combination and makes me feel. Now, we do have data with a triplet, acala-ven-obin, and that's a very effective 3-drug combination, but there's really not much that's been reported on acala-ven. So I wouldn't swap out acala-ven. I wouldn't swap out the acala for ibrutinib in that particular situation. The triplet, I think it's fine, but not the doublet.
But stay tuned. That data is coming.
Yeah, soon.
That data is coming.
And
and we have a
actually-
clinical we have a clinical trial of acala-ven plus or minus obinutuzumab, and so we will probably be reporting that trial out in the next year.
And the question is whether the FDA will actually approve ibrutinib and ven, or will it be another partner with ven in the future?
Yeah. Well, we
So,
don't think it's going to get approved.
Correct. So I'm just bringing that up. I just bring that up.
Yeah.
So, okay.
So before we get to the video cases, you want to take a crack at responding to the doc who has an 85-year-old patient with a history of hypertension controlled on 4 antihypertensive drugs, 17p deleted CLL who requires treatment, and he's bringing up the question of choice of BTK in a patient with severe hypertension. Bill, any comments?
Second generation BTK inhibitor in that situation would be my preference. I would probably steer away from ibrutinib in favor of acala or zanubrutinib. The hypertension, if they start out with hypertension, it can obviously get worse. It's usually something that occurs with time. So after they're on treatment for 2-3 years, we can see more problems with worsening hypertension. But my preference is for a second generation BTK inhibitor in that situation for sure.
So let's get into the cases, and we're going to start out with Nicole's former fellow, Dr. Bachow, who actually, I think you saw this, or you've seen this patient, or you've seen, she was actually one of your trials, or was on a trial through you. 50,
Spencer
young
wrote
patient,
the trial.
but oh, is that right? Wow, you didn't tell me that. So yeah, that was like what be interesting, good fellow project there. Anyhow, the case is really interesting because extensive cardiovascular morbidities. Actually, the patient got treated with venetoclax, and then it was MRD positive, still stopped. We're just going to get into the issue of the use of BTK in a patient like this, rather than all the details about this case, because I want you to hear the level of the type of cardiac issues you had. Here's Dr. Bachow.
Significant carotid artery disease, peripheral vascular disease, coronary artery disease, and CLL. She was originally diagnosed in April of 2015. Ultimately, her white blood cell count went up. She developed more fatigue, and the decision was to treat her. Because she was an active cigarette smoker and drank a significant number of alcoholic beverages per day and had pretty significant peripheral arterial, carotid, and coronary disease, the decision was made to treat her with a venetoclax-based regimen. And she actually underwent a clinical trial, bendamustine and rituximab induction, followed by consolidation with venetoclax and rituximab. And she improved dramatically. She was found to be in a complete remission, essentially, but she had MRD positivity. She then moved to Florida. She had a TIA. She was found to have 100% right internal carotid artery stenosis. She was on aspirin and clopidogrel. Then her hemoglobin started to drift downward. Her white blood cells started to drift upward. She had a PET CT scan that showed diffuse lymphadenopathy above and below the diaphragm, but all the SUVs were less than 5. My question for the expert is, are there any absolute contraindications to starting a BTK inhibitor in a patient with CLL? And there are many patients out there with comorbidities, including atherosclerotic heart disease. What specifically about somebody's cardiovascular risk profile would exclude you from starting them on a BTK inhibitor? Are there any scoring calculators out there?
So, Bill, I was just struck by how extensive the disease, the arterial disease that she has, and yet I wasn't sure I could really think of a reason not to use a BTK inhibitor at all. I know, what is your thought about using BTK inhibitors with people with a lot of atherosclerotic disease, Bill?
So it makes me nervous. It seems like this patient's a little bit of a victim of her own lifestyle that may have exacerbated many of her issues. But that said, people who are older in their 70s, 80s do have some underlying risk for cardiac events and cardiac toxicities associated with the BTK inhibitors. They do make us nervous. We do know from randomized trials that the risk for AFib and other significant cardiac events are lower for the second generation BTK inhibitors, that is acala and xanu versus ibrutinib. So acala, xanu would be the preferred BTK inhibitor for a patient who you're interested in putting on a BTK inhibitor for relapsed for relapsed CLL. Now, Spencer didn't tell us how long this patient had been in remission, but if they had been in remission for several years, although she was MRD positive at the end of treatment, you could theoretically go back to venetoclax-based therapy potentially for this patient, just as a way to stretch out the time in target for a BCL2 inhibition and delay the need to expose her to BTK inhibitor and the risk for cardiac event.
And oddly enough, that's exactly what happened, because when she moved to Florida, she did well for a while and then actually had a stroke, and all this stuff happened and her disease, also exploded. And I told, so when Dr. Bachow and I talked about this patient, I said, Spencer, I think right now she just had a stroke and they just put her on all this stuff. It is not the good time to put her on a BTK. So it got re-challenged on venetoclax and she's doing really well. But she's, albeit young enough, right? She's still young. So do I suspect that at some point in time she's going to need a BTK inhibitor? Absolutely. We have to think that, some of our younger patients are, they're not just going to see one agent. They're going to see both BTK and probably a ven-based therapy at some point if they're young enough and they're living longer now that patients are living longer with CLL. So there's no doubt, but it happened kind of at the time when she was having all of her cardiac and stroke and all this stuff was going on. And so we decided to avoid BTK at the time, and she got re-challenged. She was off of she was off of Ven, I think, Bill, it was over 2 years. So it was like 2 or 3 years by now. Well, no, she started in 2015. Yeah, so it was a while. Definitely over 2, if not 3 or 4 years. She's been off of Ven, so he decided to re-challenge her.
We had a case presented at another conference, Bill. Again, another patient with terrible cardiac disease. I think internal ventricular pacemaker. And somebody brought up the issue of, a patient like that, would you consider, if you could, first-line pirtobrutinib? Any thoughts?
Well, we have much less experience with pirtobrutinib than we do with the first and second generation covalent BTK inhibitors. We didn't appreciate the cardiac toxicity risk with ibrutinib, for example, for many years until we had been using it for a while. We had many patients who'd been on it for a significant amount of time, and that's when we started noticing, there's AFib that's occurring, and we're seeing more hypertension as patients have been on it for a longer period of time. The reported incidence of cardiac events in pirtobrutinib is low. However, the number of patients treated with pirtobrutinib so far and the exposure duration is limited. And I think we just need to watch that closely to determine what the true risk for cardiac events is with pirtobrutinib with time.
So I'm going to bring in another related case. Dr. Brenner actually is Spencer's partner, and they both are like case presenting machines. They can present cases all day long of every case, any kind of cancer. They come up with 50 different questions. But my internal AI, when I read these 270 questions, was cardiac issues was the number one issue that these docs have one way or the other. And this probably was the most common issue that was brought up by the docs, the scenario that Dr. Brenner is going to present.
The 77-year-old male who I diagnosed with chronic lymphocytic leukemia in 2013, significant cytopenias due to bone marrow involvement, as well as fairly bulky lymphadenopathy. He did have an 11q deletion. At that time, we treated him with bendamustine with a complete response. He then relapsed about 3 years later, predominantly with lymph node disease. And at that time, I treated him with ibrutinib. He tolerated it very well. And then in the middle of 2020, he developed atrial fibrillation, which was relatively asymptomatic, treated with a beta blocker and a blood thinner. My question for the clinical investigators is it safe to continue BTK inhibitors in patients who develop atrial fibrillation? And is it safe to keep them on a BTK inhibitor on a NOAC? Would it be safer to switch a patient like this to a second generation BTK inhibitor, such as acalabrutinib or zanubrutinib?
So what's the follow-up on the patient?
So I just elected him to leave him on ibrutinib because he otherwise tolerated it very well, and he's been fine. He has rate-controlled atrial fibrillation. He's asymptomatic. He's on his NOAC with no bleeding issues. So I've just left him alone. He's in a complete remission on ibrutinib.
So, Nicole, any thoughts? And again, we already have a question in the chat room. Dilla bringing up the issue of sudden death with ibrutinib. Are you looking for an excuse or a reason to get off of ibrutinib because of that? And basically, how do you approach a patient who develops AFib on a BTK inhibitor?
Yeah, absolutely. I mean, obviously, this is one of the more serious of the side effects when we talk about the cardiovascular side effects with the BTK inhibitors. Before we had acalabrutinib and zanubrutinib, there's no doubt that we would maintain it as long as the patient was willing to, and they didn't have uncontrolled congestive heart failure or something like that due to the AFib. If they were willing to maintain the BTK inhibitor, while obviously, oftentimes I immediately would hold. Typically in the acute phase, I would hold the BTK, let their AFib either, if we can convert them back or get them under cardiac care, and then we have the discussion. And either the patients would, depending upon part of this, to be fair, part of this depends on what their prior therapies were for their disease, because some of them really needed the BTK. Now we have Ven, so there's that open question. But prior to that, we would co-manage, and that's what we would do. Now, right now, there are some of our patients who would say, hey, if I revert back to normal sinus rhythm, I don't want to go back on a BTK, or maybe not go back on ibrutinib because I don't want to necessarily have to be maintained on cardiac medication and anticoagulation if there are other options. So this is a discussion. Our discussions with CLL patients are getting longer because of our options. Not a bad thing. But to be fair, you can co-manage. I prefer them not to be on warfarin only because warfarin, the initial trials with ibrutinib excluded warfarin due to early subdurals and CNS hemorrhage. Although, we'll still counsel patients that if they're going to be on any anticoagulation, they'll still have an increased risk of bleeding and bruising no matter what BTK you're going to use. So they need to be aware of that. But you can co-manage atrial fibrillation and a BTK inhibitor. Now, the option now also becomes, can you switch them if they're on ibrutinib to either acala or xano? And you can. I think since I haven't been giving much ibrutinib now, they're already on either acala or xano, and I would just keep them on it if they're willing to stay on with AFib. But you certainly could switch them. But it's still a risk. It doesn't mean that they can't have AFib again. But co-management would be the answer if they don't want to switch.
Bill, anything you want to add to that?
No, I agree with that strategy. I mean, it's if they don't cardioavert into normal sinus, I'll leave them on ibrutinib and medically manage their AFib as long as they're rate controlled. They do relatively well. If you can convert them and you want to keep them on a BTK inhibitor, which is usually the case, I usually will try a second generation because there is a lower risk of atrial fibrillation associated with those second generation BTK inhibitors.
So Nicole, Abdul in the chat room has a patient who's asymptomatic but has 90% marrow involvement, does not fulfill clinical criteria for treatment at this point. He thinks he's going to need treatment soon, but right now doesn't need treatment. But he's saying, with the availability of BTK inhibitors, are there situations where you would sort of stretch the traditional bar to treat CLL, Nicole? Including
I still
17P.
Oh, that's a different question. We could talk all day.
I added that on to his. Yeah, okay.
Of course, that was very smart of you. I think that, I'll still meet, I'm still waiting the traditional criteria by the IWCLL indications for treatment. I will still wait to treat somebody. There are some early intervention studies looking at, whether or not for patients with high-risk disease, should be treated earlier to see if it impacts their progression-free survival, overall survival. So stay tuned for those studies. But I won't treat them early outside of a clinical trial, if they don't otherwise meet indication for treatment. Now, obviously, For the high risk individuals, this is tricky because, we're hoping that as our therapies get better, we've already known that with BTK inhibitors and ven-based therapy, there's no doubt our high-risk players have become better players and are doing well. The question for those individuals is intervening earlier. Will that change other issues in the long run for them? Because we know that ultimately, they're even with the newer drugs, they're going to lose their response. And will earlier intervention, change that or even prevent things like Richter's? So I think those are unanswered questions. But I wouldn't, if the patient has a packed marrow, but their counts are fine and they're asymptomatic and doing well, I would still, my answer would still be to wait until they need treatment outside, again, of a clinical trial scenario.
Bill, anything you want to add to that? You were telling me that you saw a patient, I think today, who you've been following for a long time with a white count of 300,000. It just required treatment. I think there is a trial looking at treating high-risk patients with BTK when they're asymptomatic. But any situations right now where you do treat these patients when they're asymptomatic outside that trial?
So when I see patients as new patients, I'll get their prognostic factors. And so I have a good understanding of what their disease, the complex of their, or complexity of their disease is. Do they have FISH abnormalities? Do they have a mutated or an unmutated immunoglobulin gene? Many of those things, like an unmutated immunoglobulin gene, will usually correlate with eventually needing treatment. I think the one thing that you want to do is avoid treating patients who could otherwise be monitored with observation for many years. In my practice, I will monitor patients if they don't have a formal indication for treatment, but I can tell the train's coming. I can see the train coming down the track. Maybe they don't have drenching night sweats that happen more than once a week. Maybe they don't have a hemoglobin of 11, but it's coming. Then I will have the conversation with those patients and start the treatment planning process with them earlier than when they develop a formal criteria or meet a formal criteria to start treatment.
Yeah, actually, Abdul in the chat room added another comment that the patient's very, very nervous and pushing him to give treatment. I'm sure that happens a lot. So
we have that happen normally.
I bet, yeah, any patient. So let's go to another case. This is a patient of Dr. Gigi Chen, a 72-year-old man who had some issues receiving ibrutinib.
He had initially tolerated the ibrutinib quite well, and then he had developed bruising, rash. He had developed a maculopapular rash in his truncal area, so his abdomen, his back, and it was quite pruritic. He then also had just increased bruising. He was not on any antiplatelet agents or any other anticoagulants. So we had done a workup for the bruising, which was pretty unrevealing. The bruising would be kind of ecchymosis, in his abdominal area, in his truncal area, in his back.
What's the follow-up?
So we actually had to dose reduce ibrutinib to actually about half of the dosing to see if that had improved his symptoms. He still had ongoing, a wax and waning, the rash. He did not have significant hematoma, or life-threatening bleeding. He didn't feel better on the lower dose of the ibrutinib, actually opted to go back to the full dose.
So, Bill, any thoughts about this case?
The bruising is very common. We see that with all of these agents, including with pirtobrutinib. We see it with ibrutinib, we see it with acala, with xanu, and with pirtobrutinib. So that, in my view, is an in-class, even among the covalent and the non-covalent available BTK inhibitors, side effect or toxicity that we see. I have successfully been able to manage that with dose reduction. The rash we also see more with ibrutinib than with the others in my own experience. That one's a little bit harder to manage with dose reduction, and that one will be sometimes a reason why I switch them to a second generation from ibrutinib, would be the rash. But the bruising doesn't go away when you switch to other BTK inhibitors in my own experience.
And actually, Nicole, you can see here in these questions, we had a case very similar to that, asking whether you see cross tolerance in terms of dermatologic issues with other BTK inhibitors. Any thoughts about this case, Nicole?
Yeah, I agree with Bill. So for a rash, I will absolutely try to re-challenge on either acala or xanu. But Bill is correct. The bruising issue actually comes up with all of them. So it's not necessarily that switching that you can try, but it's not, in my experience, the hematomas and the bruising is pretty equal amongst the covalent BTKs. So that necessarily may not change. But for other rash mediated issues, yes, I do think that if you don't have a serious adverse event and they're otherwise, drawing very good efficacy from the class, it's nice to try to re-challenge them on an alternative BTK. So at least then you could extend the efficacy. Obviously, if it doesn't work, then you're going to be switching. You're going to be switching class.
So, Bill, I'll pick up a couple of questions here from the survey. BTK use in people who've had a CVA.
If it's an ischemic CVA, I'm not reluctant to give a BTK inhibitor. If it's a hemorrhagic stroke, I stay away from BTK inhibitors.
I see Nicole shaking her head. Nicole, how about this other? I've never heard of visual impairment. Maybe it's just a coincidence, but this doc has 2 patients with visual impairments on ibrutinib. Is that for real?
Yeah, so I mean, we have to remember that this they can give immune mediated itises, so pneumonitis and optic neuritis and visual issues, so vascular issues. So one is you absolutely want to send them to an ophthalmologist to take a look. They may need eye drops and steroids, and then you may have to stop the therapy or switch therapies. So it just depends on what's going on. But there are eye related issues, iritis and other issues that might need further evaluation and consideration. So it does happen with ibrutinib. Absolutely.
A question from Hassan in the chat room, Bill, is the mechanism of the bruising platelet dysfunction?
Yes, it's inhibition of platelet aggregation. It inhibits the ability for platelets to aggregate.
So we've talked a little bit about dose reduction. I want you to hear this next case of an elderly patient, an 88-year-old man of Dr. K.S. Kumar, who was having cytopenias on acalabrutinib, mainly a thrombocytopenia. Here's Dr. Kumar.
Oh, this is my favorite case. 88-year-old gentleman, chronic lymphatic leukemia, B-cell, diagnosed in 1994, went on surveillance till 2017. Started on ibrutinib due to progressive disease, B symptoms, lymphadenopathy, increasing white count. Ibrutinib was discontinued because he had recurrent pneumonia and sepsis. Then he transferred to me. His spleen started to rapidly increase. Platelet count dropped to 72,000. White count went up to 73. So I started him on acalabrutinib, 100 milligrams twice a day. He had difficulty tolerating it. So I reduced the dose to 100 milligrams daily. Then I went to every other day. Now he takes 3 per week, every other week, with excellent control of his counts, and spleen size is normal. It's not palpable. And it used to be 20 centimeters in size. Question, what's the lowest effective dose of acalabrutinib? It is said there will be a rebound if we stop the acalabrutinib. What's the time period that occurs if one stops the acalabrutinib?
You said that when he started the acalabrutinib, he had difficulty tolerating it. What kind of problems?
The counts will just bottom out. His platelet will go to 38,000. So it's mostly a platelet problem.
So, I saw you both sort of chuckle when you heard him bring up the issue, what's the lowest dose? Bill, any thoughts about this case? The art of oncology. Does this, any thoughts?
So it's an interesting case. It illustrates to me the fact that we don't really have the optimal dose necessarily of the BTK inhibitors that is the most effective and the best tolerated. We have active doses, and so for acalabrutinib, the active dose that was tested in clinical trials is 100 milligrams BID, but I also have had to dose reduce patients for various reasons. My opinion is the most effective dose is the dose that works. So if you go down to dosing this patient or any patient to a few times a week, and their disease is controlled, and they're continuing to have a response, then that for that patient is a reasonable dose. He asked about rebound. I would not anticipate seeing a rebound effect potentially for this patient. I assume the comment about rebound is this phenomena that we see where the disease will rapidly grow when you take them off a BTK inhibitor. You see that in patients who are progressing while on the BTK inhibitor. So if the right count's rising, the lymph nodes are growing, they're still on the BTK inhibitor, you stop it, their disease can rebound or rapidly grow. If this patient had evidence of growth of their disease, I would try to creep up on the dose or go up on the dose to gain better control of the disease if that were the case. So I might go to 100 milligrams daily or go up to the standard dose.
Do you taper people off, the BTK inhibitor in that situation if they're progressing? No. Interesting.
I don't. No.
But that's really a great insight. I never thought about that. Really interesting.
We have a trial that's fixed duration BTK plus CD20 antibody. So the question is, can you give a patient fixed duration BTK inhibitor with an expectation that you're not doing harm, you're not selecting for resistant disease, and you can retreat if the disease returns and progresses? So we have two trials. One was Xanu plus rituximab, another with acalabrutinib plus venetoclax. 2 years of BTK inhibitor, 6 cycles of CD20 antibody, and the goal is to see if we can re-challenge and if there's clonal evolution among those patients when they progress.
So, Nicole, another question from Abdul. I haven't seen Abdul in the chat room. He's putting in a lot of good questions here, asking about the issue of the bump in white count that you see in CLL, people who get BTK. He has a patient on Xanu after 6 weeks, the blood white count still 50 and 60,000. I've heard cases where the white count stays up for like a year. How do you decide whether they're progressing or not?
No, I mean, there are patients who have this profound lymphocytosis, and there is variability. It partly depends on how much bulk they have in the periphery. And as you just noted, some patients can have an elevated white count, even at a year time point, albeit usually they're coming down, but they may still have an elevated white count. It's unusual that they would be progressing. I think the concern would be if they're having cytopenias or there are nodes growing, as well as that they have their persistent lymphocytosis. I think that would be a tip-off that there's something awry, because now all of a sudden somebody is looking like they're truly progressing versus just having the lymphocytosis that often occurs from the redistribution from the organ involvement into the peripheral blood. So don't panic if the white count is still elevated. I oftentimes would used to see physicians kind of repeating their flow cytometry over and over again. And I'm like, it's not going to change. Give it time. It's okay. As long as their other counts are well, the patient's asymptomatic, they're feeling well, they're not, you don't feel any bulky or new lymph nodes, then it's okay that they still have a persistent lymphocytosis. And to get back to the other, I think it's important when Bill mentioned about the dosing of the BTKs. I agree. I think we don't know. I think back in the day when patients were coming off of chemoimmunotherapy, we didn't want to dose reduce because, for some of these patients, they were refractory, and the data initially looked really bad for patients that we were holding or dose reducing in the setting of chemo-refractory disease. But now that the BTK inhibitors and ven-based therapy have really taken over and there's far less chemoimmunotherapy, these patients are not refractory. We've kind of shown that, if somebody's getting a BTK in frontline and you need to dose reduce or hold for surgery or various reasons, these people are still doing well long term. So I think we don't have the answer, can you back off? And studies like what Bill and they are doing, I think are important because, it may be that patients can ultimately be on lower doses because they have full BTK occupancy. And I think we just don't have the answer that you probably can lower dose on some individuals and they'll do just as well.
So, Bill, here's another case from the survey. A 72-year-old woman on acala for 2 years, develops melanotic stools, hospitalized, gets transfused. EGD shows a bleeding gastric ulcer, has APC done, and now the bleeding has stopped. Would you re-challenge with acalabrutinib? Would you switch? Any thoughts about the case, Bill?
That would be a challenging. If this is the first bleed, I probably would monitor and observe this patient off treatment for a period of time to make sure her bleeding didn't recur, that she's stable. For many of these patients who've been on the BTK inhibitors for a while, like this lady who's been on for 2 years, their disease burden is down relatively low. So they can afford a time off treatment, which can be for months without evidence of progression. So this would be a case where I would probably have the patient off a BTK inhibitor, make sure if she needed treatment for H. pylori or whatever, make sure that her GI stuff was resolved, even perhaps repeat her scope, and then think about restarting her if she needed to have treatment.
So, Nicole, I want you to keep that case in mind and listen to this next case, and I'm going to ask you for your comments on both, because the next one, I think, may be slightly different because the patient's on ibrutinib. This is the patient, Dr. Brenner.
We treated her with ibrutinib, but she developed significant skin bruising, and she elected to discontinue therapy at that time. Shortly afterwards, she did have a stroke that was treated with aspirin and clopidogrel, and unfortunately, more recently developed progressive disease with a rising white count, dropping platelet count, and anemia. She does have a p53 mutation. She declined venetoclax-based therapy due to tumor lysis risk and refused hospitalization for the first cycle of therapy. And we're currently in the midst of having a discussion regarding BTK inhibitor therapy. A question for the clinical investigators is one BTK inhibitor associated with less bleeding risk than another? Is BTK inhibitor therapy contraindicated in patients like this who are on dual platelet inhibitor therapy? And is there a role to consider dose reduction with BTK inhibitor therapy to lower the risk of bleeding? And that's actually what I did with this patient. I put her on acalabrutinib 1 tablet a day, and she's doing pretty well. We now predominantly are using second-generation BTK inhibitors such as zanubrutinib and acalabrutinib. The question I have for the clinical investigators is there any difference between these two agents as far as their risk side effect profiles, such as bleeding risk, hypertension risk, cardiac arrhythmias, where clinical investigators may prefer one agent over another?
So, Nicole, 30 seconds or less. No, just kidding. We could probably spend half an hour on the last question he asked. So, first of all, any thoughts about the first case of the bleeding ulcer on acalabrutinib?
I agree with Bill. I would have been very nervous about retreating somebody who just had an active bleed, and CNS hemorrhage, same deal. I'm very leery if somebody's had a CNS bleed or a recent bleed of putting them on a BTK, although it could be, again, done later on. So I agree with Bill. I would have monitored that patient or considered if they needed to be treated during that time, an alternative agent.
How about this other case, the second case of the patient with the bruising who she stopped and didn't want to keep taking the ibrutinib? Any thoughts about that one?
Yeah, I think it's completely fair. That was not active bleeding. It was bruising. And so I think it's completely fair game to try acala or xanu in that patient. Although, again, as we noted, you can still see increased bruising and bleeding with the newer generations as well, albeit he dose reduced it. And I think that it's completely acceptable. The patient didn't want a ven-based therapy. They're older, they were 85, they didn't want to come in the hospital. I totally understand. I think if the patient progresses because they have a TP53 and need treatment in the future, then you can consider something like pirtobrutinib as well, if they still don't want to do venetoclax. So I think I would agree with the way he handled the case is re-challenge on a second generation.
And, we really appreciate these docs presenting their cases. Sometimes they are, kind of stretching things a little bit, but they want your feedback, and, we really appreciate that. Bill, any comments? You could show tons of slides, and I should point out to the audience, as we always do, we've loaded up the slide deck that we put in the chat room with really some great slides for you to take a look at. But as you can see, we're trying to really get into the granularity of the clinical management here. And, that question that he brought up, Bill, about obviously we don't have direct comparison of acala and xanu in terms of side effects. For that matter, pirtobrutinib is also an issue. But any sort of, so if you want, we, try to make a clinical scientific point is one thing, but what about clinically, Bill? Is it your impression? Do you sort of shy towards one drug or another, depending upon kind of what the toxicity issue is?
Not for any reason that's data-based. It's more for personal experience. We've done a lot of clinical trial work with acalabrutinib. We've used it a lot. I'm used to that agent, but there aren't any head-to-head comparisons between acala and zanubrutinib to know what the differences are in toxicity profile for the toxicities that you mentioned. I think one comment that I would make to Dr. Brenner's patient and question, I think he did raise an issue that we didn't touch on yet, and that is for patients who are on a BTK inhibitor, having them on antiplatelet agents and either NOAC or DOAC and aspirin. So I will not have patients on 3 antiplatelet or blood thinning agents at the same time. Only 2. That's my rule. So if I have them on a BTK inhibitor, then they'll be on a DOAC or they'll be on aspirin. I won't have them on all 3.
Nicole, again, any sort of clinical leanings that you have? We had a lot of questions of people had, I guess indirectly, it looked like there was maybe more hypertension with Xanu than Acala. Any preferences in any of these scenarios?
Yeah, I mean, I use both of them fairly commonly and on some of the clinical trials. I think that we, again, don't have head-to-head with Acala or Xanu directly. So, I try not to really pick one over the other per se. Some of that might be driven by insurances if they're not on a clinical trial. I think that if you're going to get picky about the data and you say, hey, there was more hypertension or equally the similar frequency of hypertension with Xanu and ibrutinib, and I have somebody who's hypertensive, I want to use Acala, I think that's fine. I don't think we have, the data to know if it's, going to be better or not. But I think that's completely reasonable to look at the data and sort of try to extrapolate in that fashion. I think the bigger issues are that we know that the cardiac frequency of major cardiac toxicities is less with the newer generations. And so I think that's what my main point of starting a second generation versus ibrutinib at this point for newer patients. Otherwise, I try to educate the patients about all these toxicities. And if it's not a serious adverse event, I will try to switch within the class. If I think it's something minor, I will either dose reduce or try an alternative covalent BTK to extend it if it's not like a CNS hemorrhage or active bleeding or something of that nature. And I agree with Bill, if they're on multiple antiplatelet coagulation, I'll try to talk to the cardiologist and see how we can manage that so they're knowing the increased bleeding risk regardless.
So, of course, BTK inhibitors are an important part, an increasing important part of therapy of mantle cell lymphoma. Most of the cases that we got, and all the ones we've heard up to now, are CLL, although I'm about to present a case that Spencer had of a mantle cell patient. But just to alert the audience, I mentioned earlier that we're going to do this mantle cell webinar in a couple weeks. But about 2 weeks ago, I did a program that's, I think it's already out now, an audio program, the one I referred to in the introduction with Dr. Wang, who's Bill's colleague at MD Anderson, focuses completely on mantle cell. And Bill, I know you two are kind of siloed, or he has his mantle cell department and you're over in CLL, but he really shocked me, and we're going to talk about this in the mantle cell webinar, but he right now, outside of clinical trials, using BTK up front. And just to get the audience interested to tune in a couple weeks, in older patients, he's using acalabrutinib. And in younger patients, he's using acalabrutinib plus venetoclax in some situations. This is the window 2 strategy, which is a trial that was done that they piloted there. And then in some patients, will use high-dose Ara-C after that, I guess select higher risk patient. And at the end of that, I was thinking to myself, I remember when I talked to your colleague, Dr. Henick Bachow, about 10 years ago, he said, I think that CLL is going to become the new CML. And obviously, that's pretty much what happened. It's starting to look to me like maybe mantle cell is going to become the next CLL, because I'm hearing a lot more about not only BTK, but also venetoclax. So we'll see where that heads. And again, Check it out in a couple of weeks. All right, here's Dr. Bachow's case, and also Dr. Chotsky actually had a patient, we are not presenting, but a very traumatic experience that she had when ibrutinib first came out. She had a patient die of a CNS hemorrhage, and she had some questions related to that. That was CLL, but here's Dr. Bachow with his 83-year-old man with mantle cell.
This is an 83-year-old man with a history of mantle cell lymphoma. He presented with unintentional weight loss and a sore throat. He was found to have lymphadenopathy. He had 6 cycles of bendamustine and rituximab, followed by rituximab maintenance. He had some progression in 2017. He started ibrutinib and had good disease control for approximately 2 years, but this was complicated by a GI bleed with syncope and also had a traumatic head injury resulting in a subdural hematoma. And treatment was held at that point. In October 2020, a bone marrow aspiration and biopsy showed extensive bone marrow replacement, greater than 90% with mantle cell lymphoma. He was started on acalabrutinib, 100 milligrams twice daily. My questions right now for the experts are, how do you manage life-threatening bleeding in patients with mantle cell lymphoma on BTK inhibitors? Do you just give platelet transfusions to overcome the antiplatelet effect? Is there ever a role for other hemostatic agents such as FFP, prothrombin complex concentrate, or recombinant factor 7A?
With all the newer anticoagulating agent versus old-fashioned blood thinner medications like warfarin or Pradaxa, if they are on blood thinner medication, which medication is okay to be given concurrently with the BTK inhibitors, or do they avoid all these patients in general with the potential risk of spontaneous bleeding? Do they tend to choose newer generations BTK inhibitors?
Any thoughts, Nicole?
Yeah, I mean, I think as we noted, for sure, if somebody's got a major bleed, we're all going to be very leery about re-challenging them, at least in the short term, on a BTK inhibitor, just because of the concern for a re-bleed. I think in the one case that we had before with the GI issue, sort of having them rescoped, did the ulcers heal? Is that somebody then who could be re-challenged later? I think that's more doable. CNS hemorrhage is a different beast. I think that, I think I would be very leery about putting somebody in the short term on a BTK inhibitor, and would look for an alternative strategy if possible because of the concern. And then when we talked about the different anticoagulation agents, again, I think that most of us, it's not to say I've never had somebody on a BTK and warfarin. It's just something I usually don't like to do unless there's no other option. But I would try to, if they can switch to non-warfarin anticoagulant, again, what Bill had noted about sort of depending upon how many antiplatelet agent, anticoagulant, and an aspirin, can we reduce that to just 2 agents, sort of working with the cardiologists to see whether or not there's alternatives so you can mitigate or try to reduce bleeding risk. Now, Dr. Bachow had mentioned about, can you give platelets and other agents to try to help with the clotting ability? And I think, I have not done that. I think if the patient is thrombocytopenic, that's a different issue. So depending upon the circumstances, if there's bone marrow involvement, is there something else I can do because of that? Are they thrombocytopenic that I can do an antibody into the mix and try to help their platelet count? In addition, if obviously somebody has active aggressive bleeding or issues, am I giving them transfusions or putting them on an Yes. It depends, I think, on the circumstance, but traditionally I'm not front loading and giving people, platelet transfusions or factor replacement just to try to mitigate, while I'm putting somebody on a BTK. Bill, do you have any comments about, maybe I was misunderstanding?
The one comment that I would make that I think he was asking was, if you have a patient who has a life-threatening bleed, is there something you can do to stop that? And I think even if they have a normal platelet count, the half-life for acalabrutinib, for ibrutinib is relatively short. It's a few hours. So you can, and the bleeding risk comes with inhibition of platelet aggregation. So if you have a patient who's having life-threatening bleeding, you could consider giving platelets in that situation, thinking that if he's not had recent BTK inhibitor, those platelets probably are more likely to be functional, and that would be just a temporary way to address a challenge of hemorrhage. I think that's what his question related to. I wouldn't do transfusions as a long-term approach for controlling bleeding issues in patients on a BTK inhibitor, though.
I agree.
So, Nicole, I was just thinking maybe for our next program, you think we ought to move like more into a Jeopardy format here? We can go like, bleeding for 800 or, something like that. Anyhow, someday I hope we can do something like that, but, I don't want to stretch it too far. All right, a couple more sort of related to bleeding. We'll just rapid fire here. Start with you, Bill. I'm going at the bottom now. CLL patient with acala requiring emergent major surgery. Recommendations.
Stay off the BTK inhibitor for 7 days after surgery. Don't worry about the fact that they took their BTK inhibitor this morning. There's nothing you can do about that. If they have excessive bleeding in the OR, you could, like I mentioned a few minutes ago, consider giving platelets during surgery. But they should stay off of it for a week after major surgery.
So, Nicole, somebody says, should I hold BTK therapy for my patient undergoing knee replacement? It will be on enoxaparin for 4 weeks after, has high bleeding risks. Should he hold the acala?
Yeah, I will typically vary how long to hold the BTK depending upon the severity of the surgery. So I would hold for at least 5 days, 3 to 5 days for the knee replacement prior to. He's going to be on enoxaparin for 4 weeks after has a high. If he has a, normally I wouldn't. So post surgery, if they recover quite quickly, I usually tell them, depending again on the severity. Bill had noted in emergent major surgery, we would hold for a week after. That's what I would do as well. If it's a minor surgery and they're not bleeding post surgery, I usually tell them that within a few days they can restart their BTK if it's a minor surgery. In this case, the patient's going to be on enoxaparin. If they have a very high risk of bleeding and you feel that they're so high risk that you're worried that they're going to bleed, you could hold it. I think also part of that would be dependent upon this patient's course of therapy in terms of, prior lines. Are they going to be at risk for how long have they been on their acala and doing well and things like that? But if you really felt they were high risk enough, you could hold their therapy longer.
So another question from the chat room, and then we'll go to one more case. Bill Abdul, again, he's got some great questions here. Has a patient who's been on a BTK for 3 years, hematologic CR, no adenopathy, doing great, wants to hold therapy. And so he's the patient saying, I'm cured. Why does he need to be on it? Any clinical trials looking at he brings up the analogy to in colon and prostate cancer, sort of stop and go, treatment holidays. You were sort of alluding to that before, but can you kind of go into a little bit how you think that through, Bill?
So there are no good data that address that question of stopping in a patient who has good disease control. Now, we know that in patients who come off treatment for toxicity, for example, who've been on it for a while, the median time to progression after you stop it is about 2 years. So they don't get deep remissions like they do with venetoclax-based therapy with BTK monotherapy. Now, I have seen some patients who've been on acala for like 10 years and they have converted to undetectable MRD, but it's taken them a long time to achieve that. It's generally the BTK inhibitors are thought of as treatments continuous until progression. We have a trial that we just recently published where we did consolidation with venetoclax. So we had patients on a BTK inhibitor for at least a year or longer. They received venetoclax in addition to the BTK inhibitor for 1 to 2 years with the objective of getting them into an undetectable MRD status so they could come off treatment. So those consolidation type strategies are under investigation, but we all get a little bit uneasy when we talk about stopping somebody if they've had a good response, but there isn't any data that says, yeah, that's great, do it. And we also don't have data that says, no, you can't, you absolutely cannot do that. So we do see that happening in the community a fair amount.
It's really hard not to keep asking questions from the chat room because they're just pouring in. One is better than the other, but we're almost done. We're going to do one more case. This is from Dr. Eric Lee. 59-year-old man.
So this is a gentleman, I remember he presented with massive neck adenopathy, and I started him on acalabrutinib, excellent response. Within 6 months, his adenopathy had resolved. His CT scan completely cleared. I think his counts are completely normal now. He was about a year on therapy, developed worsening myalgias. He demonstrated to me his myalgias by not being able to kind of bend and squat in my office. I held acalabrutinib for a few weeks. His myalgias resolved, and so it was related to the drug. So my questions are, this is a patient that had really excellent response to the drug. Would there be a road to switching to an alternate BTK inhibitor, such as ibrutinib, zanubrutinib, or pirtobrutinib?
Nicole?
Yeah, absolutely. This is one of those troubling side effects that I used to see a lot more on ibrutinib than I do on acala and xanu, but it could be really debilitating from a quality of life perspective, and usually resolves when you stop the drug. Dose reductions don't really help that much. You can try, but it doesn't really work. But I would absolutely try to re-challenge on a different BTK inhibitor. So just to see, given his remarkable response to therapy. So I think switching to xanu would be a fair trial.
Any comments, Bill? And also arthralgias. And is this really just one thing? Kind of both joint and, soft tissue?
So I would completely agree with Nicole. I would recommend an alternative second-generation BTK inhibitor, in this case, the zanubrutinib, for this patient. We sort of lump the arthralgias and myalgias together. And, it's hard to separate them in terms of, even when we talk to the patients, they are oftentimes not real specific about, well, I just have these aches and pains, and yeah, they're my joints, and yeah, sometimes it's my muscle. I think it's drug related, and whether it's arthralgias or myalgias, it's drug related, and it does improve when you get patients off the drug. And it can, you can manage them potentially with an alternative inhibitor.
All right, and with one more question from the chat room in. Nicole Navneet wants to know how you manage neutropenia in patients on long-term acalabrutinib.
Yeah, so the recommendations are to stop and hold the therapy. I got to tell you, Bill, I don't do that. So I typically will, if somebody's got persistent neutropenia, I'm going to give them some growth factor to maintain drug and dose reduce if needed. So, it's much more common to see neutropenia. You can see neutropenia with all the BTKs, more common to see it with zanubrutinib. It's more myelosuppressive than the others. But particularly when I'm starting the drug and patients need the therapy, I'm actually going to support them through it rather than holding therapy, waiting for the neutropenia to resolve and then start them up again. But persistent neutropenia, I'll dose reduce. And of course, if somebody is persistently neutropenic, despite me dose reducing or growth factor support, then oftentimes I might actually do a bone marrow to see what's going on, to find out is there something else I'm missing? Are they truly MRD negative at this point? Is it just drug induced? So that's typically my management, is I'll support through and dose reduction accordingly.
So Nicole and Bill, thank you so much for working with us today. I think we could go on another hour and still not even get through this topic. Audience, thank you for attending. Come on back next week. If you're not going to be in Houston, to join us at the Soho meeting. Join us online for our Thursday night, our myelofibrosis, and Friday diffuse large B-cell. Be safe, stay well, and have a great night. Thanks so much, Nicole. Thanks, Bill.
Thank you for having us.
Yeah.